Good morning to all my respected teachers and neighbor colleagues. Today, I'm presenting the Journal Club on the article that's plot 4. That is perioperative chemotherapy with fluorouracil plus leucovorin oxaliplatin doxorubicin versus ECF. That is fluorouracil or piperacillin plus cisplatin and epilepsin for locally advanced resectable gastric or gastroesophageal junction adenocarcinoma. Coming to the introduction, the docetaxel, as we all know, had benefit in the first and second line metastatic gastric cancer, but had increased toxicities. But coming to the plot, it was more tolerable than the parent basic regimen, and also it induced more tumor responses in the locally advanced resectable tumors than other regimens. So the investigators wanted to evaluate plot in a randomized phase 2 or 3 trial, phase 2 and 3 trial, comparing the perioperative and cisplatin versus plus fluorouracil capecitabine with periop-plot. In the phase 2 studies, plot was found to have a higher pathological complete remission rates of around 15% versus 6% in the ECF regimen, ECF or E6. Here, in the phase 3 study, we wanted to assess the overall survival benefit in an expanded sample size. Coming to the methods of the study, the inclusion criteria was including locally advanced more than T1 and or not positive histologically confirmed adenocarcinoma stoma or gastroesophageal junction. All the three types of CWADs, AUJ1, 2, 3, without any distant metastasis and without infiltration to the adjacent structures or organs. There had to be no previous resection of carcinoma or any chemo given, age more than 18 years. If there are peritoneal carcinomas is clinically suspected, then a laparoscopic exclusion of peritoneal carcinomas was done. LBF of more than 50% and adequate end organ function and fit for operability. Exclusion was M1 disease, that is even the METS2 periaortic peripancreatic lymph node was also taken as M1, and infiltration into adjacent structures and primarily non-resectable stages were also excluded. And then any relapsed disease or hypersensitivity to the chemo drugs planned, active coronary heart disease or NYHA 3 to 4 or peripheral neuropathy grade 2. And pregnancy and lactation also excluded, and chronic inflammatory intestinal disease also excluded. The clinical staging was done by physical examination, exophagoduodenoscopy, endoscopic ultrasound, and CT or MRI of the chest, abdomen, and pelvis. Diagnostic laparoscopy was recommended but was not mandatory in accordance with the standard of care in Germany. Randomization was based on a sequence generated with and was stratified according to ECOG, that is 0 versus 1 and 0 or 1 versus 2. Location of the primary tumor, that is type 1 versus 2 and 3, or versus gastric. Age less than 60, 60 to 70, and more than 70. Suspected lymph node involvement, that's not negative and not positive. Surgery was scheduled 4 weeks after the last dose of preoperative chemo. Type 1 GEJ cancers were underwent transthoracic esophagectomy, IOLS procedure with exception of the proximal stoma and 2-field mediastinal and abdominal lymphadenectomy. Type 2 and 3 GEJ cancers underwent transhiatal distal esophagectomy plus D2 lymphadenectomy. And gastric tumors underwent total or subtotal distal gastrectomy plus D2 lymphadenectomy. This is the consort diagram, and this around 716 patients were randomized in the study, out of which 360 were assigned to the ECF or E6 regimen and 356 were assigned to the plot regimen. ECF, among them, among the 360 patients which were allocated to the ECF, 353 patients were started on pre-op chemo, and 352 were allocated in the plot regimen. Among the 353 of the ECF, 341 underwent surgery, and among them, 187 received the post-operative chemo. And at the time of analysis, around 203 patients were dead. Coming to the plot arm, and 352 of the 356 patients were started on pre-op chemo. Among them, 345 underwent surgery, and 213 of them received post-op chemo. 166 were died at the time of analysis. Now, baseline demographics measured our like the age and median age was comparable in both arms, 62 years, and male and female composition was also comparable in both arms, and the age of 1 to 3, the percentage is also comparable with similar percentage in both arms of all the 3 types of aging. Then coming to the T1, T staging tumors which were included in both the tumors were also comparable. Composition with most of them being T3 followed by T2. Then node negative and node positive cases, most of them were node positive. And coming to the composition of with respect to Lorentz type, most of them were intercellular mixed type compared to the mixed diffuse type, and both were comparable in both arms. Coming to the outcomes of the study, primary outcome of the phase 2 was the rate of pathological complete tumor regression, whereas the primary outcome of phase 3 was to evaluate initially the disease DFS was planned, but then it was changed to overall survival, which is defined as time from randomization to death. And secondary outcomes were margin-free resection rates, DFS rate, surgical morbidity and mortality, and adverse events as per CTCA version 3. Even a co-primary endpoint was planned if at all the test failed. But coming to statistical analysis, the estimated median overall survival as per the MAGIC trial in the ECF or ECX group was around 21 months. Based on this, the calculated sample size for the study was 658, with which was calculated based on allowing for a dropout rate of 15%, along with 80% power for a two-sided log-rank test and alpha error of 0.05. The sample size was increased to 714 to allow for a dropout rate of 24%. DFS and OS were analyzed by Kaplan-Meier method. Time to event comparisons were done with log-rank model, and all the models were compared with using the chi-square test. All p-values were two-sided. Coming to the results, among the ECF or ECX arm, 314 patients underwent tumor surgery compared to 94%, that is 336 patients in the plot arm. R0 resection rates were higher in the plot arm, that is 85%, and PAT-CR rates as per the phase 2 study was higher in the plot arm, that is 16% compared to the 6% in the ECF arm. Now coming to the overall survival and disease-free survival. In the intention to treat population, the median overall survival was higher in the plot arm, that's 50 months compared to 35 months in the ECF or E6 arm. And the OS at 2 years were 2, 3, and 5 years were constantly higher in the plot arm, 68 versus 59, and then at 3 years it was 57 versus 48, and at 5 years it was 45 versus 36. Coming to the disease-free survival, the median DFS was 30 months in the plot arm compared to 18 months in the ECF or E6 arm, with a hazard ratio of 0.75 and p-value of 0.0036. This was a subgroup analysis in the node negative and node positive population of the intention to treat, which showed there was in the node negative population, it was 84% of OS at 2 years compared to 65% in the ECF arm, and 53% in the plot arm compared to 49% at 5 years. In the node positive population, it was still higher in the plot arm, that is 67% in the plot arm compared to ECF arm, that is 60% at 2 years, and at 5 years it was 44% in the plot arm compared to 34% in the ECF arm. This was the subgroup analysis of overall survival curve in the CVER types 1 to 3, and that in the gastric adenocarcinoma group. In the CVER types 1 to 3, the OS at 2 years was 69% in the plot arm compared to 58% in the ECF arm, and it was 30% in the plot arm compared to 30% in the ECF arm at 5 years. With respect to the gastric adenocarcinoma group, the overall survival at 2 years was 70% in the plot arm compared to 61% in the ECF arm, and 55% in the plot arm compared to 47% in the ECF arm at 5 years. This is the toxicity chart, but Dr. Mega will take over with respect to the toxicity.
Morning, everyone. I will be presenting on the chemotherapeutic regimens in use in the study. The control group received ECF or ECX. Basically, the control group received 3 cycles pre-operatively and 3 cycles post-operatively. It is a 3-weekly regimen, ECF and ECX. The dosage were epirubicin 50 mg per meter square on day 1, cisplatin 60 mg per meter square on day 1, and 5-fluoro. The third drug was fluoropyrimidine, either 5-fluorouracil or capecitabine. 5-fluorouracil was 200 mg per meter square as a continuous IV infusion on day 1 to day 21. Or patients were also given oral capecitabine The dose was 1,250 milligram per meter square orally on day 1 to day 21. The experimental group which received plot was the patients received 4 pre-operative and 4 post-operative cycles. It was a 2 weekly regimen. The doses are here the dose was of 5-fluorouracil was 2,600 milligram per meter square on day 1 only as a 24-hour infusion. Leucovorin was also given with it with 200 milligram per meter square on day 1. Oxaliplatin in a dose of 85 milligram per meter square on day 1 and docetaxel 50 milligram per meter square on day 1. The toxicity profiles were different for both, but it was consistent with the previous studies of for each the regimens. The most frequent grade 3, grade 4 toxicities were neutropenia. It was more in the plot regimen. Approximately 50% patients had grade 3, grade 4 neutropenia as compared to 40% in the other arm. The plot regimen also had more of infections and diarrhea. 18% versus 9% infections in 18% infections in plot arm and diarrhea 10% versus 4% in ECF. The only toxicity which is grade 3, grade 4 toxicity, which is more in the ECF or ECX arm was nausea, most probably because of the use of cisplatin rather than oxaliplatin. There was no significant difference in the toxic death or hospitalization or discontinuation of the regimen because of the toxicities or any serious adverse events. The main difference between the two regimens was both the regimens had a chloropyrimidine and platinum compound. The third drug was the difference. In plot, it uses docetaxel, while in the ECF or ECX, it was an anthracycline epidobicin. Plot was a 2-week regimen, and the other one was a 3-week regimen. And in plot, it uses oxaliplatin, which contributed to less nausea and vomiting. The schedule and doses of chloropyrimidine was also different. In ECF or ECF, the cumulative dose of chloropyrimidine was more as compared to the plot regimen. Just few words for each of the drugs used. 5-fluorouracil is an anti-metabolite. Basically, it is an inhibitor of thymidylate synthase. It has many metabolites which get incorporated into RNA and DNA and thus inhibit replication and RNA transcription as well. It's almost 80% of the 5-fluorouracil is metabolized in the liver by enzyme known as DPD, dihydropyrimidine dehydrogenase. The patients who have this deficiency they will develop more toxicity, so that is a contraindication for the same. The most common adverse effect of 5-fluorouracil is diarrhea. There are other concerning side effects as well, like neutropenia, pulmonary embolism, thrombocytopenia, and leukopenia. This is just a diagram showing the same, the mechanism of action. The 5-fluorouracil is metabolized into chloro-uridine diphosphate and monophosphate and gets incorporated into DNA and RNA. Oxaliplatin and cisplatin both are alkylating agents. They are non-cell cycle dependent inhibitors of oxaliplatin. Basically, it's a platinum compound. It produces DNA crosslinks, both intra-DNA, inter-DNA, and DNA protein edits. The predominant mechanism is production of intra-DNA adducts. It also works synergistically with chloropyrimidine compounds. The adverse effects mainly are fatigue, peripheral neuropathy, diarrhea. The contraindications are if a patient has a history of platinum hypersensitivity anaphylaxis, grade 3, grade 4 peripheral neuropathy, or severe renal impairment. Docetaxel is a beta-tubulin inhibitor. It binds to the beta-tubulin and stabilizes it. Thus, it inhibits the M phase of the cell cycle. It also reduces the expression of an anti-apoptotic gene, BCL2, thus promotes the apoptosis in the tumor cells. The side effects include infusion reactions, myelosuppression, febrile neutropenia, diarrhea, and fluid retention. It can also cause peripheral neuropathy, both sensory and motor, which is a very common long-term side effect of docetaxel. The contraindications are any person with chronic lung conditions like COPD. epirubicin is an anthracycline. It is basically a epimer of doxorubicin. The mechanism of action is similar to docetaxel. It is basically it inhibits topoisomerase. It also inhibits beta tubulin as well. The side effects are myelosuppression and it is cardiotoxic. And there are other side effects like constitutional symptoms like fatigue, dermatological side effects like alopecia, and GI toxicity like mucositis, nausea, and vomiting. Thank you.
Morning, respected teachers and dear colleagues. So I will be going ahead with the discussion of background and discussion of the trial, that is a plot. So till now, we know that in resectable gastroesophageal and gastric cancer, plot in perioperative setting, plot is a better option than ECF. So I'll be discussing why do we decided to use plots instead of how we come to plot that from ECF to plot, and how do we the increased toxicity associated with plot, then still why is it better than ECF, and the future perspectives that are coming. So this is the magic initially. Initially we know that the magic trial already had proven the efficacy of ECF in perioperative setting, as it improved the OS and PF as well in this lower esophageal and gastroesophageal cancer as per compared to surgery alone, with a benefit of 13% in 5-year overall survival. But the 5-year overall survival was still 36%. So we needed another regimen which is better than this and can give better outcomes. And we decided to do some modifications with the triple drug regimen, that is the ECF. This magic B trial STO3, they decided to use a biologic agent along with the ECF, but it was a negative trial. Bevacizumab was used compared, and the addition of bevacizumab did not result in better results as compared to the ECF. Then the third drug, that is epirubicin, it was replaced with the docetaxel. That is have done in the plot 4, and also we decided to replace more nephrotoxic cisplatin with oxaliplatin. So this is how we came to plot 4. And also, why did we decide to compare 3 cycles of ECF with 4 cycles of plot? There is a trial, that is the OE5 trial, which had compared 2 cycles of CF with 4 cycles of ECFs, and here the treatment intensification did not favor any beneficial outcomes in the patients. So, and also why CRT was not incorporated in the study. Can we add CRT and have improved outcomes? So, this is the trial table of the phase 3 trials of the perioperative chemotherapy of the gastroesophageal cancer. As here, we can see initially this France-based study, which was used 5-week cisplatin, they initially had compared a doublet versus surgery alone in the perioperative setting. And here we can see the 5-year overall survival is 38% as compared to 24%. And similarly, the MAGIC trial, the trial that I just said, the 5-year overall survival is 36% as compared to the 23%. And in plot 4, which is the Germany-based trial, in this study, you know that there is 15 months of benefit in the median OS, and also the 5-year overall survival is 45% in the study. And this is the E5 study, OE5 study, where we can see that there is no benefit of adding 4 cycles of E6 as compared to 2 cycles of CF. The median OS is 26 versus 23 months only. So why docetaxel? How did we decide to put docetaxel instead of epirubicin? So we know that there is proven role of docetaxel in metastatic and second-line setting in this gastric and gastroesophageal cancers. And with DCF, the combination DCF regimen is more toxic than the plot regimen. This is statin was changed to oxaliplatin, and the 3-weekly regimen was changed to 2-weekly. Why 2-weekly? Because the dose of docetaxel was reduced. It was more tolerable than the 3-weekly regimen. And in phase 2 studies, plot that is the plot 2 phase 2. We already know plot is more tolerable and more than DCF, and the perioperative plot in the phase 2 had 300 patients, which had proven efficacy in reducing and increasing the PAT CR rates from 15 to 16%. Now, so whether incorporation of CRT now increase the efficacy of this perioperative therapy. So in the NSCT setting, the trial study, it was increased, the NSCT was followed by surgery, but no perioperative chemotherapy. But in the top here, the comparator arm was ECF, and 3 cycles ECF in perioperative setting surgery was compared with NSCT in the NSCT-RT in the new addition. That's 2 cycles of ECF, NSCT-RT, followed by surgery, followed by 3 cycles of ECF. So top study, the phase 3 efficacy results is still awaited. We don't know if it has improved outcomes over this part or magic. And in this next critics, this trial is phase 3 data of the use of CTRT in the adjuvant perioperative setting, but post-op. They had in the comparator arm was 3 cycles of ECF perioperative, and they had compared like three cycles of ECX surgery and then followed by CTRT. And this was a negative trial. They had used concurrent capacitive and cisplatin in the post-op setting, and it was a negative trial, not improved outcomes. Then this plot 4, as we analyze the data, we see that the control arm, that is ECF arm, had comparable median survival with the reference trial of MAGIC, that is 25 months median OS. In MAGIC trial we had seen, and here we had also 35 months. It is quite good comparator arm. Control arm is quite good results. And also there's similar surgical mortality and morbidity in both the arms. Though there is increased toxicities with plot in the study, and but approximately 56% patients do complete all the cycles, and the rate of vascular admission is similar between both the arms, and also there is less than 1 toxic life-threatening toxicity associated with the arms. So yes, we can manage plot, and also it has proven efficacy. And the chemotherapy toxicities were also consistent with the previous trials. Then this grade 3 for neutropenia, plot arm has 50% grade 3 for neutropenia as compared to 40% in ECF arms. And as Dr. Minda has already explained, the related differences between the 2 arms, more increased nausea, vomiting associated with ECF, and increased risk of infections and neutropenia in plot, but they were manageable. And there was slight increased toxicity reported in the this trial in both the groups due to maybe stringent monitoring, the use of questionnaires, and also 2-weekly toxicity monitoring were there for plot, as opposed to the 3-weekly for ECF. So that is a kind of disadvantage for the plot arm. But then other limitation, coming to the limitations of this trial. So initially the total follow-up is 43 months, but we had this 5-year survival rates, which was just an estimation because most of the patients were censored at earlier time points. But however, this 5-year survival rates may change with longer follow-up. The sample size calculation was based on median survival and pre-specified follow-up time of 6 years of total follow-up time, which was achieved. So another thing is that the primary endpoint, it was changed during the study. So initially they had decided to select the disease-free survival as the primary endpoint, but then during the study, the committee had decided to change it to overall survival. Since both the endpoints were equally met in this study, so this is achieved. And the next is regarding the location. Another thing is that use of the PT and PN staging, that in this study plot, and as previous studies have used the PT and PN staging of the for comparison of the both the arms as opposed to the PTNM study. So that is another limitation. And another thing, the location, that is location of the in the gastroesophageal as compared to the gastric. So in gastroesophageal adenocarcinoma, we will have another like upcoming the cross trial, which has suggested NHCTRT followed by surgery is also doubling of the benefit of the survival benefit. And and also in the plot for perioperative, they had included only adenocarcinoma. In plus, both adenocarcinoma and squamous cell were included. So we still don't know, like for lower esophageal junction, whether to choose which one is better, which one to choose one over the other. So the ESOPIC trial is currently recruiting and evaluating. In one is randomizing this plot 4 versus cross arms, and then we can know the results. Thank you.
So all 3 of them did a good job presenting this. Any questions on this trial?
They changed the endpoint from BFS to OS. It's an adequately powered for this.
It's actually the difference in survival is very significant. It's almost 30% more. So probably that was a good call because we'd always want OS as an endpoint. Makes sense.
So biologically, do we have an explanation why oxaliplatin works better in GI tumors as compared to cysts?
Hmm, okay. So even around, this is published in 2019, 2010, 2012 also, in metastatic setting, they found somewhat the same thing. Biologically, I don't know. But the same thing was seen in stage 4 cancers also around 7 to 8 years before this. And they actually, when they said that oxaliplatin is better than cisplatin, they also said that maybe capecitabine is better than 5. So those, that was seen around 5 to 7 years back. So biologically, I don't know. Any other doubts on this? So the reason, this is a old trial, of course, but one of the reasons for just presenting this is that this is one of the seminal studies that you should know and know. Okay, so everyone should read this paper. Right? It's an important paper. After around 8 or 10 years, this was one of the first trials which showed this kind of a benefit in survival. So you should know this trial as well as the not just the outcomes, but toxicity potential. Okay. Next. Good morning, respected seniors, colleagues. Today we are going to present article on adjuvant nivolumab in resected esophageal and gastroesophageal junction cancer. So I am going to start on basics of nivolumab. Nivolumab is a fully monoclonal IgG4 antibody which binds to PD-1 receptor with high affinity and specificity. So after nivolumab binds to PD-1, it inhibits the PD-1-PDL1 interaction and activates the T cell recruitment, which helps in tumor. Indications of nivolumab. Nivolumab was approved by US FDA for the treatment of melanoma in 2014, RCC in renal cell carcinoma in 2015, metastatic non-small cell lung carcinoma in October 2015. After that, it has been used in colorectal cancer with microsatellite instability high or mismatch repair deficient, esophageal cancer, classical Hodgkin's lymphoma, pleural mesothelioma, and hepatocellular carcinoma. So this article is on adjuvant nivolumab in resected esophageal or gastroesophageal junction cancer. So this is a phase 3 double-blind randomized placebo-controlled trial which was studied at 165 study locations across 27 countries. So the study population which was included is stage 2 or 3 esophageal or gastroesophageal junction cancer, adenocarcinoma or squamous cell carcinoma, neoadjuvant chemoradiotherapy plus surgical resection, which is R0 performed within 4 to 16 weeks prior to randomization, residual pathologic disease, YP more than or equal to YPT1 or YPN1, ECOG PS0 to 1. Additional key inclusion and exclusion criteria were patients must have been disease-free as documented by complete physical examination and imaging studies within 4 weeks prior to randomization. Tumor tissue from the resected site of disease must have been provided for biomarker analysis, including tumor cell PD-1 status. Exclusion criteria were cervical esophageal cancer,
not received concurrent chemoradiotherapy prior to surgery, only chemotherapy or only radiation prior to surgery, stage 4 resectable disease, patients with previous malignancies, unless a complete remission was achieved at least 5 years prior to trial entry. Patients with active, known, or suspected autoimmune disease, except for those with diabetes or hypothyroidism requiring only hormone replacement. Patients who require systemic treatment with either corticosteroids, which is more than 10 milligrams per day, or other immunosuppressive medications. Patients with symptomatic interstitial lung disease, HIV or AIDS, and toxicities associated with prior anti-cancer therapy received first anti-PD-1, anti-PD-L1, anti-PD-L2, and anti-CD137 or anti-CTLA-4 antibody therapies. So the stratification factors which are used are histology, squamous versus adenocarcinoma, pathologic lymph node status, more than YPN1 versus YPN0, tumor cell PD-1 expression. So this is a means in this study, patients were two arms were there, which were divided into 2:1 population. So in nivolumab group, 532 patients were included, and in placebo group, 262 patients were included. Nivolumab was given at a dose of 240 mg 2 weekly into 16 weeks, and after that 480 mg every 4 weekly. Nivolumab was maximum, means total treatment duration was up to 1 year, or the recurrence or the unacceptable toxicity. And placebo was given 2 weekly into 16 weeks. After that, 4 weekly. So in this study, the primary endpoint was disease-free survival. Secondary endpoint was OS rate at 1, 2, and 3 years. So the baseline characteristics in nivolumab group and the placebo group was almost comparable. Median age 62, 61, almost same. The male patients were 84% in nivolumab group and 85% in placebo group. ECOG status 0, 1, comparable. The histology was 29% of squamous cell carcinoma in nivolumab group and 71% adenocarcinoma patients. So toxicity profile of nivolumab in general and in our study. So immune mediated rash was 9% in previous study. Grade 3, 4 toxicity was seen in 1.4%, whereas in this study, immune mediated rash was seen in 24%, but grade 3, 4 was seen in less than 1% patients. Immune mediated pneumonitis, 3.1% in previous study, grade 3, 4 toxicity in only 1%, whereas in our study, it was seen in 4% total, but grade 3, 4 was seen in less than 1 patient. Immune mediated colitis in previous studies were 2.9%, grade 3, 4 toxicity in 1.7%, whereas in our study, total GI toxicities were seen in 17% and grade 3, 4 toxicity in less than 1%. Immune mediated hepatitis 1.8% in previous study, whereas 9% in this trial. Immune mediated endocrinopathies 13.7% in total in previous studies and 70% in this trial. Nephritis and renal dysfunction 1.2% in previous studies, 1% in this study. So in our study, immune-mediated rash, immune-mediated hepatitis and endocrinopathies were seen more, but the grade 3, 4 toxicities were almost comparable to the previous studies. So this is toxicities compared in nivolumab group versus the placebo group. So the adverse effects leading to discontinuation of the nivolumab was seen in 13% in total, whereas it was seen in 8% in the placebo arm. Any serious treatment-related adverse effects were seen in 8%. Any grade was seen in 8% in the nivolumab group, was where it was seen only in 3% in the placebo group. In short, nivolumab is a well tolerated and the majority of the treatment related adverse effects were only grade 1 or 2. Treatment related adverse effect with potential immunological etiology. Grade 3-4 toxicities in endocrine, GI or hepatic, all these are less than 1% or equal to 1%. So majorly were grade 1 to toxicities. I'll give hand over to.
So regarding the methodology we saw and the inclusion and exclusion criteria, the endpoints which were considered in this, the primary endpoints was disease-free survival, which was the date of randomization to the first date of disease recurrence or death, whichever occurred first, before subsequent anti-cancer therapy. Secondary endpoints which were explored in this were overall survival, which was the calculated as the time interval between randomization and the patient death or the last follow-up. Secondary endpoint otherwise being survival at 1, 2, and 3 years. Certain other exploratory endpoints were also assessed in this, which included a distant metastasis-free survival, and there were patient-reported outcomes as well, which was the FACT-E questionnaire and the European Quality of Life 5-dimensional scale questionnaire. So according to that, the patients' reported outcomes were assessed. So this statistical analysis goes like about 440 events of the disease recurrence or death were targeted in this to provide approximately 91% power for the trial to detect an average hazard ratio of 0.72. Interim analysis of the disease-free survival was triggered when at least 85% of the 440 events had been observed. The statistical significance based on 396 events of disease recurrence or death observed at this interim analysis required the p-value to be less than 0.036. Hazard ratio with its corresponding two-sided 100 minus 100 into 1 minus the adjusted alpha confidence interval was estimated with the use of stratified Cox proportional hazards model with the trial group as the only covariate in the model. And the disease-free survival in each group was estimated and plotted according to the Kaplan-Meier method. So we saw that the baseline characteristics were already highlighted in that the patients having performance status of normal 0 was 58% in the nivolumab arm as compared to the 60% in placebo arm, and performance status was 42% in the nivolumab arm, more or less similar to the placebo arm. So more or less the similar lines was there, even though the ratio was 2:1 in the nivolumab arm and the placebo arm. Predominantly adenocarcinoma was the histology type in this study, and squamous cell carcinoma was a little underrepresented, but it was similar when compared to both the arms. The results of the studies were the disease-free survival. Patients who received nivolumab had a significantly longer disease-free survival compared to those who were on placebo. The estimated median DFS was 22.4 months in the nivolumab arm versus it was 11 months in the placebo arm, with a hazard ratio of 0.69 and a confidence interval 95% between 0.56 to 0.85 with a two-sided p-value of 0.0003. There was 31% reduction in the risk of disease recurrence or death with nivolumab. For oral survival, an blinded review of OS did not indicate any detrimental effect on the survival with nivolumab. However, the OS survival was not yet reached. So this is the Kaplan-Meier analysis of the disease-free survival. You can see the curves are well separated in the nivolumab and the placebo arm, and there was a median disease-free survival of 22.4 months compared to 11 months in the placebo arm. So you can see that the adenocarcinoma and squamous cell carcinoma as well, disease-free survival was better. If compared to in the squamous cell carcinoma in the nivolumab arm, it was 29 months, and in placebo it was 11 months. As compared to adenocarcinoma nivolumab, it was 19 months as compared to placebo 11 months. So nivolumab benefit across most subgroups, including tumor type, PD-L1 expression, and tumor stage. Subgroup analysis revealed that, however, benefit not significant in patients receiving radiation doses outside the standard range. Patients with pathological complete response were excluded, so the specific outcomes were not captured. This was the subgroup analysis, and this is the forest plot estimating it. almost most of the parameters being proving that placebo as compared to the placebo nivolumab did better. So metastasis-free survival, the median distant metastasis-free survival was 28.3 months in the nivolumab group and 17.6 months in the placebo group. Risk of distant recurrence or death was 26% lower with nivolumab than with the placebo. So the safety and adverse effects are already highlighted in the previous slides.
Good morning. Today I want to discuss about the background of the study and the discussion about the study. Why immunotherapy in G junction and esophageal cancer? What is the rationale for use of immunotherapy? When we describe about the biology of this lower GA and esophageal and gastroesophageal junction cancers, we'll see most of the lower esophagus and GE junction cancers in the proximal part of the stomach. They will have most of the MSI microsatellite instability high with hypermutations and MLH1 silencing. MLH1 is a mismatch repair gene. When there is a silencing of the mismatch repair gene, there will be more activation of the mitotic pathways and there will be more leads to high mutational burden. When there is a high mutational burden, there will be more chances of the infiltration with tumor infiltrate, more chances of accumulation of the tumor infiltrating lymphocytes around the tumor microenvironment, which lead to the better responses to the immunotherapy. Coming to the studies supporting the immunotherapy in esophageal cancers, these are the two studies where they studied in the metastatic and recurrent settings about the immunotherapy in the esophageal cancers. First one is the Attraction 3 study, where they studied about the nivolumab versus chemotherapy, that is docetaxel versus or paclitaxel in unresectable advanced or recurrent esophageal squamous cell carcinoma who are refractory or intolerant to prior 5-FU-based therapy or platinum-based therapy, where they found there is a 23% reduction in the risk of death and there is a 2.5 months improvement in the median overall survival. And most patients are alive after 18 months, that is 31% versus 21%. And the survival improvement in the study is independent of the tumor PD-L1 expression. And this conclusion of the study was that nivolumab displays better safety and tolerability compared to the chemotherapy. That is the treatment-related adverse effects grade 3, grade 4 are more in chemotherapy, that is 63% versus 18% in the nivolumab arm. And another immunotherapy study, that is the Keynote 181, where they studied the pembrolizumab versus docetaxel, weekly paclitaxel, and irinotecan in the advanced or metastatic squamous cell carcinoma and adenocarcinoma. They studied in both esophagus and the GE junction cancers, where they found that the median overall survival is around 2.6 months benefit, and the benefit is in the CPS score, the combined positive score greater than 10, and the estimated 12-month overall survival rate in this study is 43% with the nivolumab group versus 20% in the chemotherapy group. And the pembrolizumab had better tolerability with grade 3, grade 5 treatment-related adverse effects are about 18.2% only versus 40.9% in the chemotherapy group. Why nivolumab in the adjuvant setting? What is the need of nivolumab to include the adjuvant setting after NACTRT in esophageal cancer and gastroesophageal junction cancer? Coming to the standard modality therapy in the lower GA and lower esophagus and gastroesophageal junction cancers, it is the neoadjuvant chemoradiotherapy followed by surgery. That is the tri-modality therapy is widely used as a standard of care. The risk of recurrences following tri-modality therapy remains high, especially in patients with residual pathological disease. And it is more when the node is positive compared to the tumor, compared to the T stage, the end stage determines the high risk of recurrence after tri-modality therapy. Immunotherapy demonstrated superior survival in previously treated unresectable advanced and recurrent esophageal cancers as we depicted in the previous studies. The Checkmate 577 study is the first global randomized study where they evaluated the checkpoint inhibitor in the adjuvant setting after tri-modality therapy. Coming to the discussion of the study, as we discussed that there is a high chances of recurrence, that is around 70 to 75% of chances of recurrence in the residual pathological disease after the readjuvant chemoradiotherapy followed by surgery in this group of patients, that is esophagus and G junction patients, and more seen in the node positive disease. And in this study, the 50% of patients are lymph node positive. In spite of that, there is a 31% reduction in the risk or death with doubling of DFS, that is 22.4 months seen in the nivolumab group versus placebo. And when you see the Kaplan-Meier curves about the disease-free survival, there is a sustained separation, and there is a separation that is a very well separated curves, and there is also a sustained separation, which may lead to us to throw as there is maybe a good benefit in the overall survival also, which is a secondary endpoint of the study. And the hazard ratio favored nivolumab over placebo in most of the pre-specified groups, such as in histology, in squamous cell carcinoma, there is a high DFS benefit, that is 18.7 months versus adenocarcinoma, it is only 8.3 months. And in nodal status, greater is the nodal status. If it is N1, it is a greater benefit with nivolumab compared to node negative. And greater is the grade of tumor, nivolumab is have a higher benefit. And compared to the site of disease, the esophageal cancers have a more benefit compared to the GE junction cancers. And in the previous studies, we found that the CPS score is the determinant of the benefit of with the immunotherapy, which is not with our study. In our study, there is, in this study, they found that the benefit was irrespective of the PDL1 status, whether it is less than 1% or more than 1%. And the interesting point is that the time of initiation of nivolumab had seemed to be influence the outcomes. That is, the patients who were started on adjuvant nivolumab after at least 10 weeks after surgery had a better benefit compared to the patient who started nivolumab within 10 weeks. Because this may be because of the prolonged recovery may be needed after the trimodality, intensive trimodality therapy, which lead to the better tolerance and better outcomes. And the risk of distant metastasis-free survival is 26% lower in the nivolumab group, and the duration of the metastasis-free survival, there is a benefit of around 10.7 months with nivolumab group. And nivolumab became adjuvant option in this group of patients, that is G junction and lower esophagus after melanoma. Incidence of serious treatment-related adverse effects leading to discontinuation of therapy are less than 9% with nivolumab, and compared to 3% in the placebo group. With 86% of the patients in our study, they received 90% of the planned dose of nivolumab. Compared to the major differences of this study with the standard cross protocol, the major differences in the study were there is no specified standardized protocol of readjuvant chemoradiotherapy in the study, because they included patients who received concurrent chemotherapy either with paclitaxel carboplatin or cisplatin 5-FU or 5-fluorouracil oxaliplatin. They included 3 subsets of the patients, and most of the patients received cisplatin 5-FU in this study. And the mean radiotherapy dose, as in prostate, we know that is 41.4 gray. And in this study, the mean radiotherapy dose is quite higher, that is 45 gray. And the similarities between the cross protocol is both included locally advanced carcinomas of esophagus and predominantly adenocarcinoma histology. Coming to the conclusion, nivolumab is the first adjuvant therapy with statistically significant and clinical meaningful improvement in the DFS, that is double of DFS, in resected esophageal cancer and GE junction cancer, calling adjuvant chemoradiotherapy. And nivolumab is well tolerated with acceptable safety profile. And these results represented the first advance for this group of patients, potentially establishing a adjuvant nivolumab as a new standard of care. And coming to the future perspective, we have to study because NACTRT followed by surgery is the standard modality of treatment, mostly to the lower esophagus and severe type 1 groups. In severe type 2 and type 3, mostly we'll go for perioperative chemotherapy followed by surgery. We have to study in this group of severe type 2, type 3, whether addition of nivolumab benefit with perioperative chemotherapy. Thank you.
Good job, all three of you. So any questions on this, and then maybe we can point out three, four things that I felt like.
So in this cohort, the maximum was adenocarcinoma.
Yeah.
But how common do we see adenocarcinoma in about the GE junction to give an NACPRT? And for GE junction tumor adenocarcinoma, we use plot rather than NACPRT. One is that, and the other
Questions?
sir, in our institution, like in our population, we do not see so common adenocarcinoma about the G junction, like mid and lower trace of paper. And if we are seeing G junction adenocarcinoma, we see commonly, we do not use NACPRT, we use plot rather than NACPRT. So how much is this reproducible here? And second is, even in this cohort, adenocarcinoma did not show survival, like a very good survival. So like I think 8.3 months and
Yeah.
squamous was 18.7. And the squamous cell carcinoma population was hardly 29%.
Okay, so the first thing is that, if you're talking about population per se, we anyway see more distal cancers than proximal, right? This is clear. In the West, it is now proximal. So, which is why this data has come from the West, amongst other reasons. Now it depends. I mean, it's a question, and this question we've discussed in other forums also. So, do you take location or do you take histology as your primary determinant of treatment? Right? That's what you say. But there are people who say location. No, and it's a fair thing, right? So, if it is near the esophagus but with some gastric involvement, right, then both options become viable. Okay, that is the answer. It is essentially an institution and region specific practice. If you have clearly above the G junction, right, and it's adenocarcinoma, a lot of people don't actually favor the cross protocol. But if there is some involvement below the G junction and stomach, a lot of people would favor the plot protocol. That is the answer to that. What was the second one? Your second question? Yeah, so that is the same thing seen even in cross, no? I think yesterday I had shown that the curves for squamous cell are like this, and for adeno it's like this, and the same thing is reflected here. That's all. That is probably an effect of the radiation given before and how these tumors are biologically different compared to squamous. Okay, so I mean that is an extension of that. But even with that, around 70% more survival difference is there even in adeno. Right, it's 12 and 20. So that is still significant. Right? So if you use cross, then this is a very good option. Any other question? Yes.
So last second, can we use low dose neutrophil?
No answer. No, I'm going to use what the pharmaceuticals tell us. No answer. Probably should not, right? Because the whole low dose concept is primarily when it's MSI high, right? In all these other cohorts, you don't know. If you can't give full dose, then I don't think you should give it, but no answer. And I don't think that answer will come also, unless you guys do it right. Write it up as a thesis. Any other question? Okay. Anything else? Okay, so what percentage of patients after cross have apraxia?
Almost 50%, adeno 20%.
Correct. Okay, yeah. So overall it is 30%, 29% in the original paper. Okay. So first thing is that this definitely took, and we know that in squamous cell, almost 40 to 50% of patients probably don't even need surgery because they have apraxia, right? So obviously this took a worse cohort of patients. They all had residual disease. So that is one thing that you should keep in mind. And the other thing, now I don't know how many of you spotted this. Yeah. So every curve, one sec. Yeah, every curve has crossed here. Did any of you pick that? No. So when I was just reading this again yesterday, they have not given any explanation as to how they have assessed the survival. because they have everywhere said proportional method only. Ideally, the curves cross and it's clear, right? It is kind of crossing here, and the other one also it was crossing. Here also see there's some cross. At least visibly, I think it crosses, right? But so I'm not sure in the paper they have not written anything as to whether they used different method of analysis. So that is something to look into. And why they were so close initially is something that we should, because see all your division starts happening at 3 to 6 months only, right? Somewhere here. So and even in overall, I think the net, yeah. Somewhat here only it starts. So why it starts only after 6 months is an interesting question to see. And third, in the paper, they have not given a reason for their assumptions. Where did they get this data from to say that this is the survival in those patients who have not attained PATCI? In the end, they got lucky that the assumptions worked out and there was a disease survival benefit. But for those interested, go read the paper, they're not given it anywhere. Why they took these assumptions? Okay, the stats are complex, but they're not given a reason why the assumptions were taken. From where did they get the data? It's not given, right? And I think with time, this will show an OS benefit also, the way the curves are separated. The other thing was, I'm checking the slides. Are your slides here? Can you just put your slides? There was no correlation with PDL1 status also. So that is another reflection of PDL1 being a very poor representation of response or lack of response with immunotherapy. Okay. Yeah, where is that? What yours? Your slides. The first plot, just like the first plot. Next one. Yeah, so if you can see the tumor cell PD1 expression, right? They're pretty similar. Of course, the one with less than 1% is actually on the left, which does not make any sense. And this has been seen repeatedly when you're using PD1, even in gastric cancer studies. But if you're interested, you can go check out the Southeast Asian study in advanced gastric cancers. PD1 less than 1% is actually this side, and PD1 more than 1% is the other side. So it just says that this is a poor marker. And if at all you're going to use CPS or TPS, and that too plus minus, but it is what it is. PD1 alone is not a marker of response or not a response in this group of patients. That is something you should remember. Right. Other than that, I think it was well presented. Any other questions?
But is there any comparison of CPS, PPS,
Okay. In terms of prediction for outcomes, so the Southeast Asian study, in gastric cancers was Kipox or SOX plus nivolumab versus Kipox and SOX, and a secondary analysis showed no correlation between PD-L1, TPS, CPS. They said that probably in gastric CPS is slightly better in prediction, but the PD-L1 alone, no go. That's the take home from that is.